Let's switch gears and talk about SIADH. Instead of too little ADH, there is too much ADH. This excessive ADH in the blood causes an excessive insertion of these aquaporin channels, which results in increased water retention. Thus, the urine is excessively concentrated. This results in a low sodium, as the water is more prevalent in the serum. ADH can be secreted by not just your pituitary. It's secreted by a host of other cells as well, and usually in certain pathologic settings. For example, the brain will secrete ADH when there is irritation of the meninges. So we may see ADH in meningitis. In the lung, the type 2 pneumocyte produces ADH. We commonly see patients with a bad pneumonia having low sodiums as a result of too much SIADH. The GI tract also can create SIADH. Typically in patients with gastroenteritis, this is probably an evolutionary way of protecting ourselves from becoming dehydrated in the sense of a sick child. Additionally, some drugs can cause an excessive secretion of ADH. Let's go through what are these things that cause it. In the CNS, tumors, meningitis, encephalitis, hemorrhage, vasculitis, and surgical trauma. All of these things can result in a transient or more permanent SIADH. In lung tissue, certainly pneumonias, but also even bronchiolitis can cause SIADH. Patients with cystic fibrosis may develop SIADH, and certainly certain lung malignancies, although exceptionally rare in children, can cause SIADH. Gastroenteritis can cause a mild SIADH, which can cause problems if unrecognized or if rarely severe. Also, certain medications can cause SIADH, and we typically think of some of the psychiatric medications. The tricyclic antidepressants, the serotonin-specific reuptake inhibitors, or SSRIs, but also PPIs, or proton pump inhibitors, as well as ACE inhibitors can cause SIADH. So we may sometimes simply find a patient where we check a Chem 7 and we say, hey, look at that, they have a low sodium, and this is how we make the diagnosis. This is usually on patients with fairly mild disease. And by mild, typically these patients are asymptomatic if their sodium is low, but still above 125. A patient with a sodium of 130 isn't really going to notice. They're going to be accommodating that okay. However, in these severe cases where the sodium gets low and below 125, these patients can develop lethargy, confusion, you may see papilledema on exam as their brain is swelling, or they may develop seizure. Some of these symptoms depend on the speed at which that sodium has been falling. We'll talk about brain accommodation at the end, but if that sodium has been falling very gradually over time, the brain can accommodate that and they can have fewer symptoms. If the sodium fell very rapidly, patients can get in trouble in terms of CNS disease very quickly. The diagnosis of SIADH can be somewhat complicated. Typically, we'll see a low sodium. A sodium in the blood should be really less than 135. The serum osmolarity should be also low, and the urine osms should be high. The urine sodium is going to be high. Remember, the reason the patient is having a high water in the blood is because of an insertion of those aquaporins. So the sodium is still coming out. The urine sodium will be high, and the fractional excretion of sodium, which is determined by this equation here, is more than 0.5%. So let's think about how we fix sodium. When we're fixing sodium, be it high or low, we need to do it slowly. And that's because sodium shifts that are rapid can cause problems in the brain. Let's look at this closely because I think people tend to get confused about which problem causes which problem in the brain. Imagine here we have a brain cell and a blood vessel. These two compartments need to have the same osms in them. They need to have the same osms so that there aren't fluid shifts one way or the other. If fluid shifts into the brain, one would get cerebral edema. If fluid shifts out of the brain, what we typically see is central pontine myelinolysis, which is really bad. It's a disturbance of the pons, which can cause problems with the basic functions of the body. So now let's imagine we have a certain number of sodiums in the blood. This would be, let's say, a normal number of sodiums. Likewise, the brain will create small proteins that exist along the surface of the brain cell, and we'll call those idiogenic osmoles. So these small, tiny proteins are providing an osmotic force that balances out the sodium and allows a prevention of fluid shifts one way or the other. Now, if a patient were to get hypernatremic, let's say they had diabetes insipidus, and they were gradually becoming more and more hypernatremic, the brain could adjust by creating more osms. These osms would balance things out and would allow that patient to continue to function even in the presence of a high sodium. We would see this, for example, in a profoundly dehydrated state. However, if we were to go in and try and fix this problem quickly, let's say the patient had a sodium 180 that had been there for a long time, and we went in and gave them very hypotonic fluid and rapidly removed the sodiums from the blood space. What would happen now is fluid would flow out of the blood space and into the brain, and that would cause cerebral edema. So an overly rapid correction of a long-standing hypernatremia leads to cerebral edema. Let's go back to this brain again now. Here we have a patient with a normal sodium and a normal number of idiogenic osmoles. Let's say this patient now develops hyponatremia. The brain will accommodate accordingly and downregulate the idiogenic osmoles so that we have an equal amount of osmotic particles in both compartments and no fluid shift. If we see this patient with a sodium of 120, let's say they have SIADH, and we were to rapidly correct the problem by bringing up their sodium too quickly, we would have suddenly fluid shifting out of the brain into the blood, and there is when we would be at risk for central pontine myelinolysis. I hope that clarifies that whole thing for you nicely and easily. So if we have a patient with SIADH, we want to bring up their sodium slowly. We may initially give 3% saline injection, but only in cases where the patient has symptomatic hyponatremia, for example, seizure. If this child is actively seizing, we're going to give 3% saline boluses until the child is stabilized. This will prevent further brain edema. However, now we have to repair things fairly slowly. And we're going to gradually give fluids such that there is a slow sodium rise of about 0.5 milliequivalents per hour or no more than 12 milliequivalents per day. That means if the patient has a sodium of 120, we should be taking several days bringing that sodium back up. We may need to free water restrict the patient to about 1 liter per meter squared per day to achieve an appropriate water stasis for this patient. In patients where restriction of fluids is not possible, we can use dimeclocycline. Dimeclocycline inhibits renal activity of ADH, so it may inhibit the activity of the excessive ADH in the blood. Ultimately, the goal for SIADH is to treat the underlying disease. The reality is that for cases like pneumonia or meningitis, treatment of the condition usually results in a resolution of problems. I hope this lecture has clarified for you the differences between diabetes insipidus and ADH. Thanks for your attention.